The EMS socket system takes harmony vacuum to the next level. Dynamic response, better linkage, better connection, better proprioception. These are really significant advantages to the EMS over standard socket technology. Hi, I'm Carl Kaspers. I'm the inventor of EMS socket systems. I started working on the EMS because I'm an amputee, and although I was getting along reasonably well, I recognized that I was moving around in my socket, even under vacuum, and that I was not as stable as I could be because of this. The most important aspect of the EMS is its ability to be dynamic in nature and make adjustments and changes to the socket environment as you're walking and running and doing the activities that you're involved in. This technology is a wonderful product for athletes and high-activity people. It is also significantly important for anybody who is walking or exercising. If you're an ambulator, this is going to make your life better, and you're going to have less issues in your daily life if you're fit in an EMS socket. This will be a complete video covering the casting, modifying, fitting, finishing, and troubleshooting of an EMS socket system. So as you can see here, we've taken this nylon sock and we've put it over his limb momentarily here with all the panels that we're going to utilize to create the definition that we need in our socket. Before we get started here, I want you to understand a few things about the knee and the BK limb and the changes that are taking place during flexion and extension. When you flex your leg, the head of the fibula moves approximately a ½ inch and internally rotates. When you extend the leg, it'll externally rotate. So it's imperative that we catch these motions within the socket so that when you're in the socket and locked down under vacuum, we don't interfere with these movements and we don't create high pressure loads or low pressure areas because of the incongruency between the socket and this residual limb. So I have here splints that have been cut out to demonstrate how they're cut and how they're shaped. We start with a 6-inch panel like this, 5 layers. If you have a larger limb, sometimes you'll need more layers in order to get enough stiffness in it when it settles so that we don't distort it in the other casting procedures. That panel, the first panel, when cut, looks like this, and that fits on right at patella tendon level, captures the borders of the patella and the anterior and proximal aspects of the head of the fibula, because remember, that's moving up and rotating inward. This panel, the reason that we're using the 6-inch plaster is because we want to capture this medial flare, because as he bends his leg, this medial flare becomes very, very prominent, and we want to capture that increased circumference and back down to the tibia. And if you don't do that and you wait till your second splint to capture that, now you're going to be casting in about 6 to 10 degrees and you'll no longer have that expansion of the medial flare. So we want to make sure that this first splint is long enough along the medial side to capture this expansion and then back down to the tibia. Our second splint is done in 6 to 10 degrees of flexion. You're picking up the lateral posterior border of the tibia, and you're coming over and now picking up the rest of the head of the fibula, so that now we've got this covered, and it creates a track to allow this fibula to move and not be impinged on by your socket. This should end about 3/8 of an inch proximal to the distal end of the tibia. That way we will not create a bullnose in your casting when you do your circumferential wrap. And this circumferential wrap is primarily done to contain the soft tissue. It's very important that you make that wrap 3 inches or so above proximal patella, so we have enough coverage when we make the EMS to do a good job for you. Now that we've covered the panels and everything, we're now going to demonstrate how you actually take a cast. And you can see here that we have saran wrap placed over the liner. So when the liner is donned, normally people will use some lubrication to get the liner on. It's pretty imperative that you don't use lubrication in the process of casting, because the liner can slide down through these extreme ranges of motion that we're going to have the patient go through. So make sure you get all the air out and get the liner on, and then put some saran wrap on. This will really help you in removing your cast and making it easier on your patient. So we have just a nylon casting sock that goes on here. I'll just put this on, and you bring it up above your liner, and then you want to pick your liner up like so and tuck the sock underneath that liner, and then pull it back up. The liner that we use, and is really probably the most important part as far as liners go, is a urethane liner. It has unique characteristics that the other liner materials don't have, and its ability to transfer loads and create a more even pressured environment, which in the long term will help and reduce the amount of sweating that you'll have within your system. So we highly recommend that this is the liner that needs to be used within this system. I know that most people like to use indelible pencils and things, but the issue with that, again, because of the extreme ranges we're going to be taking the patient through, those marks are going to move, and they're never going to be where you thought you put them when you take your cast off. There's really no need to use an indelible, because we're going to identify everything and get it locked in the socket. So now we're going to go ahead and cast the limb. One thing I think is important to remember: don't cut your splints too short, because when you wet them, they shrink up some, and you may end up not getting the coverage that you're looking for when you're applying these splints. This first splint goes on, and it's going to encompass the patella all the way around, about 1/8 inch off of the borders of it. It'll come up to the top of the condyles, because we want to capture the flaring in of the condyles as they taper off to the femur. It's important when we apply this splint that we get it placed properly on the limb. You've got time. Don't rush it. Make sure that you've got everything. I can identify the fib head here. I'm going to make sure that that's covered in the areas that we were talking about. Oops, we're just dropping down here, and we're going to get that locked into place. Now we're going to pull another nylon over the top of this, this is a 4-inch piece of stockinette, and we use this because it allows to draw a vacuum very easily, and it doesn't get infiltrated with the plaster, where you're going to lose your vacuum pressure. So now we're going to just take and very gently pull this on, making sure that we don't disturb that splint position that we've put on. You can check that, and you can just take this extra stuff on the end, roll it over and up. Our casting sleeve here, we usually squirt a little alcohol in here, turn it inside out, give it a shot of alcohol. That makes it slide on itself very easily. So we're just going to run that up on his thigh. And I'm going to have the patient assist me in creating a seal. We'll attach the vacuum. And you'll notice his leg is still straight, okay? So we're going to draw this vacuum first and get everything locked down and the splint locked down so it isn't going to move when he flexes. Now we're going to take him and we're going to flex him just like so. And you can see how rounded and full these femoral condyles are. If you don't capture the femoral condyles in this fashion, when they bend the knee, there isn't room for the knee to expand. It'll force you out of the socket, and that's not what you're looking for. When you're in that socket, you want to be there constantly. You want to let this panel set. I know it's hard to sit there, but it's important that you let this plaster set hard enough so we will not distort it in any way with the other things that we're going to be doing as far as extending the leg and a second panel and then wrapping over it. So I use my fingernail and I make sure that I can't dent that with my fingernail. Then I know I've got a good set to the plaster. When you take your holes in and out of the attachment to the casting balloon, it's a good idea to hang on to the receptacle so when you pull this out, you don't tear the casting balloon because it can be torn in the process of pulling that out. Okay. So now we're going to remove this wicking sock that we put on. You want to be very careful when you pull this off that you do not dislodge the underlying plaster that we've just done. So we take the first layer, then we're going to take the second layer, and I just hold my thumbs here to keep it into place, and I pull that off. Okay. Now I'm going to have the patient flex again, and you can see that everything stays in place, nothing's getting pushed away or moved, so we've accommodated the width of the condyles very, very nicely. Now I have that splint that we had pre-cut and showed you, and again what we're looking to do now is contain the rest of the head of the fibula and the whole medial flare of the tibia, like so. And then we'll do the same thing. We'll put the bag on, we'll flex them to about 8 to 10 degrees, and we'll draw a vacuum, and we're going to let this splint set good and solid again. So now we're going to untuck the sock from underneath the liner, because when we get our wrap done, we're going to reflect the top of this sock back over the top of the cast so it's nice and clean, and when we pour it we don't have to deal with the sock coming loose from the edges. So I'll just get it off the top there. Now remember, this third wrap is 3 inches above the proximal patella poles. And we're going to cast in 12 to 15 degrees, wherever we can get this nice relaxation of the patella so we capture all the borders of the patella. And this plaster will set up faster because the heat, the exotherm from the underlying plasters will cause this plaster to set quick, so you have a little less time to work with it. So just make sure that you get enough on and you wrap from proximal to distal and get the tension that you need or the thickness that you need right at the get-go. This is where this heavier sock really comes into play, because if you use a nylon, the plaster can fill the nylon and you can lose your vacuum. So on this third and final wrap, the things that are really important is, one, we're really containing all of the soft tissue now and keeping that from being displaced into other areas of the socket. We want the length of this third wrap to be a minimum of 3 inches proximal to the patella poles, or the top part of the patella. So we take that off, and again we're just going to take off the outer sock. A nice thing with the urethane also in removing this is if I have my patient grab a hold without fingernails and stretch this up, I'll be able to pull that off. And that's what the Saran wrap really helps with, is the ability to get that off without having to cut it. If you have a patient that's really atrophied, let's say somebody wearing a supracondylar, suprapatella type socket, a lot of atrophy up here, then put a cut strap in over the top of your liner prior to doing that final wrap. It's important. When we look into the cast now, we should see these individual panels really not very prominent at all. Everything is blended very nicely, and about the only thing that you'll have to deal with after you pour your cast is you get a little puckering on the side when you're going back into 90 degrees, and it's just a matter of filling or cutting those off. And everything's here. You can see it. There's just, you aren't going to miss anything.
So now that we've taken our 3-stage vacuum cast, we've created a positive mold from that cast, which I have right here. One of the most important things that we need to do is to document where MPT is. And by doing that, I've created a reference point 4 inches above MPT, so that when I start modifying and I lose my MPT identification, I always know where it is 4 inches down from this mark. So what I've done is created a mold that we need to reduce in order to produce the EMS socket. When you take your 3-stage casting, you'll always see that you get a little raised area in the mold right here from where the patella moves to the anterior at 90 degrees of flexion. The first thing you'll want to do is remove that so that your socket does not gap in the anterior. As you can see on the mold, we only smooth the mold in the anterior. Your reductions are done from behind the posterior of the fib head to the midline on the medial side, on the posterior of the medial flare. From MPT to 1.5 inch down, we want to do a 2% reduction. From 1.5 inches to 2.5, we want to do a 3% reduction. And below 2.5, we want to do a 3% reduction. When you have accomplished all that, make sure that you modify the distal end of the mold so that you maintain the same shape that we had before we started the modification. Whatever shape you leave on the distal end of this mold, the limb is going to be forced to take that shape because of the vacuum. So you want to make sure that you create the appropriate shape on the distal end of the mold. So now we have our modified mold. As you can see, we've removed the void that was created from bending the limb down to 90 degrees of flexion. We've maintained the shape over the condyles, and all the reductions were done in the posterior. It's very important for you to draw the identification marks that we need to create the proper EMS socket for you. So the identification marks that we need are the proximal patella, the proximal medial lateral poles of the patella. Make sure that you include your circumferential line around MPT, and then your standard trim lines for what your normal socket design is. We also need to include the adductor tubercle. That's very important because we want the EMS socket to mimic the shape of the limb in that area. In the posterior, be sure that the center of your W starts at MPT. We will increase that raise it up when we go to the EMS socket, but for your regular socket, it should always start at MPT. And as you notice with this socket, our W has moved over quite a bit to the lateral side. We want the center of the W to be exactly between the hamstrings so that it doesn't impede knee flexion. On the lateral and medial side of the trim lines, we want to make sure that when we start down on the medial lateral wings of this socket, that we create about 1.5 inches slope into the back of the W. This will help you control your bunching of the liner and the tissue material so that the knee flexion is not restricted. Once you've established all of your trim lines and your identification marks that we requested, be sure to do that in heavy indelible. I usually wet my indelible to create a bolder reference point. We're going to wrap this with a fiberglass wrap, and we want those markings to transfer over to the inside of the fiberglass wrap. Once you've done your fiberglass wrap, you're going to turn your mold around to the posterior and simply take your cast saw and remove it from the posterior, take your fiberglass wrap off, and then staple it back together. Fill out your order form for your Autobach EMS socket and send in to the address on the form. Be sure you extend your fiberglass wrap 3 inches proximal of the top of the patella. If you make sure that you follow all of these directions carefully, you're guaranteed to get back the socket in the proper fit that you're looking for.
So when you receive your EMS back from our production facility, you will see that there are 2 trim lines on the socket. The proximal or top socket trim line is a trim line that we recommend that you start with your patient, and you should not change this for at least the first 2 weeks unless you're having pressure issues. The second trim line that you see is the trim line recommended starting point for either your definitive socket or for an additional test socket. So the next step is to create the distal end chamber in the socket, either your test socket that you're making or in your definitive socket. And the process that we go through to accomplish this is to take a 1/2 inch piece of P-light. We're going to heat this P-light. We're going to shape it down so that it takes the shape of the end of the socket, and then we're going to make sure that it's attached in place. I use a little double back tape on top so this stays in place, and then you can use saran wrap, or you can take a nylon stockinette like this that I'm using, and you can pull that over, pull it down, make sure it's good and tight. And now what we're going to do is take a plaster wrap of the distal cap and your EMS up to at least to include about 1/4 inch above the trim lines for your outer socket. As you can see, we have a key in the back of the EMS socket, and that's to keep it locked into place against rotation and dropping down into the chamber that we're creating on the distal end. Very important that you keep the definition of this key so that it locks very well into your outer socket or test socket. So as soon as your plaster wrap is solid enough to get out without deforming anything, you take it off of this model, and now we're going to fill that plaster cast. Once that's set, then we'll cut down a strip, and we'll take the plaster cap off, and now we've got your model, and that model includes this extension in plaster. But you don't want to leave it all rough like this. You want to blend the edges into the EMS, which is no longer on the cast, so you won't hurt anything. So just blend this all down so it transitions very nicely into the plaster model that you've made. Clean that up, and you're ready to pull test socket or go about laminating your definitive socket. So now that we have the EMS back, we're going to be fitting the patient with it, and we need to establish that the EMS is fitting the patient properly so that he's got or she's got good contact on the distal end, and the EMS is going up to where it's supposed to be on the patient's limb. This is a one-ply super sheath, and we recommend the use of this because it allows the corrugations in the socket to get through and hook up with the liner in a much more appropriate way. If you use a straight nylon sock or something like this, the issue you're going to have is it'll shred that sock, where this is more stretchy and it yields easier. So we're just going to slip that on till it goes all the way up and the top of the poles are contained underneath this extension on the EMS. And then we're going to come down to the bottom. You're right there. Going to come down to the bottom and push. And you should, without pushing this or forcing it up, you just want it on where it belongs. You come down and you push like this, and he's right there. There's no space between him and the end of that EMS. That's what you're looking for. You don't want any space where a vacuum can increase the negative pressure. I think the thing that's really important to understand with the EMS and the corrugations that we have inside of here, when we put this under vacuum, the limb is drawn to the inner socket, and actually the corrugations in this inner socket actually protrude and will leave rather significant markings on the outer side of your liner. And that's really, really important to hook up, because what we're really trying to accomplish here is to hold the limb in place without having to squeeze it excessively, which will cause immediate loss in fluid, and then you'll have volume changes and you start to have the issues that you're chasing around. If we keep him locked in place and he can't go in or out and he's totally contained and locked to his socket, things will be much, much better. So most generally, when you're fitting a new patient into the socket, it should be a one-ply fit, and everything should be right on the money. So an initial fitting, oftentimes we do not put a sock over the outside of the EMS. It dawns into the socket without a sock. And there are channels in this outer side of the EMS that allow for vacuum to be pulled all the way up through the EMS and onto the thigh, where it then will go down into the socket. So it's really not an issue, and it minimizes the amount of air that you'll be dealing with in your socket. But that's not to say if your patient is going along and they're starting to lose some volume and you need to adjust for that, you have two places to do it: on the inside of the EMS or on the outside. And both of those solutions will work very well. You can also add a patch or a P-Lite patch, or if you have a specific area you want to apply more pressure to, you can glue that to the outside of the EMS. It'll stay on, and it'll be more like what you were doing in sockets a long time ago. I don't use any patches. I only use volume management to sustain my relationship in my socket. So as you can see here, the sock he has over his liner extends up onto his thigh, and then the liner extends above that without the sock. So we get a good seal on the liner and we get a good seal on the skin. That's really important to hold everything in place very, very well. No gaiter is required over the top of the EMS or over the outer socket. We just don't have any issues to speak of with sleeves, and they'll last much longer than what you would normally expect. So now we're going to don the EMS socket, making sure again that everything's in place, and then I'm going to have the patient step right into that socket, stand up, pull up his sleeve, create a seal. It's very easy, very simple to do. Then get a few pumps in that nice vacuum system. Now the patient should be extremely comfortable and should be having significant amount of flexion capability and good range of motion, but always in a supportive fashion. Should not have any difficulties, any areas bothering. Should feel no up and down motion to speak of with the limb inside of the socket. So if you fit your patient with the EMS and they've been out in it for a while and then all of a sudden they start to have distal issues and they aren't getting into the socket all the way anymore because they've shrunk up, so they've gained space and everything else is fitting fine, there's a very easy way to take care of this for your patient. Put a filler beta seal in the bottom. It's a silicone product and it's very easy to do, and I'll demonstrate that now for you so you see how that takes place. So the first thing you do is you want to put this on your patient and make sure that you're all the way on, and if you've got room like this in the bottom, that's not a good thing because you need to be in total contact. So we're going to have to fill that. So I'm going to pull his sock off. We're going to take a little saran wrap here, and we're just going to put that on to protect the liner. And then I'm going to take the beta seal, I'm going to turn this straight up, and I'm going to shoot this material into the bottom of the socket. And I know just about by feel how much we needed to put in there. And so we're just going to keep doing this till we're about where we need to be. Now put your limb down. We want this to be right perpendicular so that everything stays in place. This will take approximately 4 minutes for this silicone to seal and harden, and then you can withdraw the limb from the socket. Any of the thermofoams that you might use to make up for the difference in distal end contact are not good choices because they pack out under vacuum, weight loading, and the heat that the body produces. So this is a much better product to use because it'll be consistent in its diameter and will not pack out and will do what you're expecting it to do for your patient. So oftentimes we run into amputees that have really an inordinate amount of soft tissue on the end of their limb, where they're going to be constantly dealing with volume changes in the distal tissue for quite some time. So if you start off and you have to add some silicone in here and you reestablish that contact and they go along for 3-4 months and all of a sudden they're kind of getting back into that same issue or problem, then it's very easy to pull this silicone out and reestablish contact by doing another pad. And you can keep doing that as long as the rest of the limb is fitting well in the EMS socket. There are a couple situations regarding limb profile that I think we should talk about here momentarily. If you have a limb that's fairly new and it's kind of bulbous and it's a little bigger in an area, after you get through the knee it gets a little bigger and then it tapers down, it can be very difficult to get into the EMS socket because the nodules inside of the EMS will hook up with your sock right away and it won't let you slide through to the bottom of the socket, which is absolutely necessary. The other scenario would be when you have a longer limb and it starts to curve back in like a normal shaped leg, and when you try to go through, this curvature will push you over against the side of the socket and make donning very difficult. So in those cases, what I do is I reduce the corrugations in the area that the limb has to pass through in order to get to the bottom of the socket. That has worked extremely well, and it allows them to slide through like they would if they were in a test socket, and then hook up to the rest of the socket, and including the area that they're going through. There's still connection there, and there's still a coefficient of friction that is excellent for them. So this is something that I do when I'm working on the EMS in our lab, and when I see these characteristics, I automatically do that for you. I'd like now to thank everybody very much for taking time to view this video. I hope it has been instructive and helpful for you. And if you have any issues or need to talk to somebody else, please contact out-of-box representatives or myself at EMS.